Hi, so today's lecture is about the protozoans. Let's continue from the protozoan series and let's talk about the parasites. We've spoken about the parasites, now let's talk about the worms, okay, the helminths. So, helminthes, they are of two types, okay, they are of two types, and the first type is the platyhelminthes, the other one is the nematohelminthes, okay, so platy, and nemat. Platy is tapeworm or fluke. So let's look at flukes. Let's look at all the flukes that are present. Okay. After that, we'll go into the tapeworms that are present. Okay. So for now, let's look at the flukes. So you have the liver fluke. You have the GI fluke. And then you have a very important called as schistosomias. Schistosoma. And you also have a fluke that infects the lungs, so it's called a lung fluke, or you could also call it paragonimus. Alright, lung fluke, and when we get to that, we'll talk about that fluke. Okay, so for now, when you think about worms, I want you to segregate them, okay, because when you don't segregate them, it just becomes more difficult to understand the worm and the different pathogenesis that it can cause. Okay, so for now we have to think of this. Okay, you have to divide it in this sense. After that, you have to think of a very important concept. Okay, a very important point as well, and that is that something is common between all of them, and the something that's common is, I'll write this common things. Snail is something that is common, and snail is an intermediate host in all of them. Okay. And the second thing that is common is that they have metacercaceae or cercariae. That is the infective form. This is something that's common in all of them. So this too you have to remember. Okay. The only difference is that in schistosoma it is a cercariae, that is the infective form. And the last thing that is common in all of them is that they all have operculated eggs, except, again, exception is schistosome. So till now, everything is that is common we've spoken about. So now, once this has been established, let's directly jump into each of these flukes. And the first fluke that we should talk about, is the liver fluke. And before we talk about liver fluke, just a very basic 11-12 standard thingy. Fluke is a platyhelminthes. Platyhelminthes is a flatworm with no body cavity. They are monoecious. Again, all are monoecious except the schistosoma. So the schistosoma really set itself different. So you want to remember that a lot of MCQs could come from schistosoma because it really set itself different. Okay, and as I told you, metacercariae is the infective, except in schistosome where cercariae is the infective. And habitat is the GI, lung, various tissues depending upon the type of fluke. So let's talk about liver fluke directly. When I talk about liver fluke, I want to talk about fasciola hepatica, I want to talk about fasciola gigantica, okay, and then I want to talk about clonorchis, and then I want to talk about the last but Ophisthorchis. When you think about clonorchis, Ophisthorchis, you should think about a very important point, that eggs are embryonated. When you talk about fasciola hepatica, fasciola gigantica, you want to think about eggs being unembryonated. So this is the first set of difference. Now what is common in all of them is that metacercariae is the infective form. But here metacercariae is as a fresh water plant. Okay, where in in fasciola hepatica. So I'm talking about fasciola hepatica or fasciola gigantica. Okay, right now, once I've written about as I've explained it. So freshwater plant has a metacercariae. Okay, it's on the surface. You ingest the freshwater plant. When you ingest it, your metacercariae exist. Metacercariae exist. They form the lava. Now you tell me it's a fasciola hepatica. The lava is going to reach where? It's going to reach obviously your biliary tract, retrograde. It reaches biliary tract unembryonated. Eggs passed in bile, that is reaches feces. Then this eggs gets embryonated, and then obviously again it forms the cercariae, or this embryonatus actually infects the snails, and all of this I do not really want to get into. It infects the snails, and then it again forms the cercariae, and the cercariae becomes the metacercariae. So the embryonated egg reaches the snail, and snail is the first intermediate host. Okay. So this is fasciola H and fasciola hepatica and gigantica. Now the point that I wanted you to note is the unembryonated egg. Simple. What about clonorchus or Ophis torquis? Ophis torquis. For this also is the same. Metacercariae infect, metacercariae exist. Metacercariae is, but here it's present in the fish. Exist, the lava is formed. Lava reaches the biliary tract. Biliary tract, it gives embryonated eggs. So when you see the eggs as a stool culture, and then it infects the snails. From the snail, it forms the cercariae. Again, obviously, it's going to form the metacercariae. What I'm saying is that when you see the stool culture, you'll see embryonated eggs, and these embryonated eggs are a diagnostic point when you're differentiating between clonorchus and the fasciola. Okay. So what is the patient going to present to you as? Patient in fasciola hepatica, fasciola gigantica, clonorchus, Ophis torquis. Okay. So FH and FG group and clonorchus group. Okay. FH is going to show everything related to the cholangitis, cholecystitis, cystitis. Okay. Cholelithiasis. Lithiasis means stones in the bile, stones in the gallbladder. Cholangitis means inflammation of the biliary tract. Cholecystitis is the inflammation of the gallbladder. Okay. Now, it can also lead to biliary cirrhosis as a complication. But what is important, is that when you are looking at the clonorchus group, it can cause cholangiocarcinoma. And this is really, really interesting, cholangiocarcinoma. How do you want to diagnose it? You take the specimen for stool, you check the stool, you do sedimentation technique, okay, and then you see operculated eggs. Unoperculated is only in schistosoma. Also, you can do PCR, you do serology, and you check for antibodies. Now here you can check for a lot of antibodies. You want to treat it. You want to treat the first group by something like a clabendazole, and the second group by a praziquantel. But the question asks is triclabendazole. Okay. Again, for the case of opisthonis or clonorchus, okay, so as I told you, stool can be taken, but stool is for fasciola hepatica, fasciola gigantica. If you want more sensitivity, you want to do a duodenal aspirate, which is more sensitive for the clonorchus. Okay. Also, you can check for antibodies. In clonorchus, you will have an IgG4 antibody. Okay, so you'll have an IgG4 antibody in clonorchus and Ophis torquis. That about being the Very important answer. uh, how does it cause cholangiocarcinoma? The question is, how does it cause cholangiocarcinoma? The idea is that it is releasing certain toxins. Okay, what clonorchis is releasing certain toxin. So the toxin causes ductal hypertrophy. Ductal hypertrophy. Okay, plus fibrosis. So when this occurs, ductal hypertrophy plus fibrosis, it finally leads to cholangiocarcinoma. And cholangiocarcinoma itself is a neoplastic tissue of ductal hypertrophy as well. Correct. And not just that, it also has a lot of stroma as well. Okay. So once that has been covered, let's look at the GI fluke. GI fluke. What is the GI fluke, my friends? GI fluke is fasciola busci. Okay. I just want to remember this one particular name. Why? Because I don't think GI fluke is that important in its pure sense. Because apart from GI, they usually ask for liver flukes, okay? And they also ask for schistosoma from this particular category. And first, fistula bushka is the largest fluke. It's the largest fluke that we men are infected by. So that's why I want to talk about that. What does it cause? It has the same cycle as most as the flukes, as the fasciola. So is it going to have, because it's a fasciola, do you think it's going to have an unembryonated egg? Obviously it's going to have an unembryonated egg. So it's going to have the same life cycle as we spoke about in fasciola hepatica. So I'll just write it down, metacercaria. Again, it's going to be on the plants. Then it's ingested. Then it exists. Okay, metacercaria exists. Larvae is in the duodenum. Okay, eggs, but unembryonated. Embryonation, snail, cercaria, and then again metacercaria. Again, this is what they usually ask: unembryonated or embryonated. Simple answer. We do not want to stress about it. What are the symptoms? Well, the symptoms are, first of all, it is affecting the duodenum and jejunum. So it can have pain, diarrhea. Okay. If it is causing ulceration, it can also cause bleeding. Not occult bleeding, but certain amount of bleeding can be seen. And in certain cases, it can also cause obstruction. It can cause obstruction of the small intestine. Now that is risky. Okay, so egg is obviously operculated. You do stool, you see for the egg. Egg is unembryonated and operculated. And how do you treat the fluke? Fluke, you do a praziquantel. You see a fluke, you do a praziquantel, except in the fasciola where I gave a triclabendazole. And you can also think about triclabendazole again here, okay, as an alternative, because triclabendazole, because in fascial hepatica again we used triclabendazole. Now there's the other fluke that I told you I will speak about, in spite of it not being a GI fluke, is the lung fluke, and it's called paragonimus. It's the penguin fluke, paragonimus, and the penguins like eating crab, so it's caused by crab. Is it embryonated? Is it unembryonated? It's unembryonated. Okay. Why is it unembryonated? Because the penguins eat eggs as well. They eat their unembryonated eggs. This is how I remember. Okay, and crabs unembryonated. Is it operculated? Obviously, it's operculated. Okay, what does it affect? It affects the lungs. Why does it affect the lungs? Because I told you it's the lung fluke. Okay, what does it? So what is its life cycle? Again, metacercaceae. You know this. You know the drill, right? Metacercaceae exist. Lava in the duodenum. Lava reaches the lungs. Actually, sorry, it's the exist of metacercaceae. They penetrate. Okay, the lava are not formed here. The adult lava are formed in the lungs. They penetrate the duodenum, and they somehow via the venous plexus, via venous, via the venous plexus, obviously through the hepatic portal and stuff like that. They reach the lungs, and in the lungs they form uh, fertilized egg. Now this fertilized egg is given off as unembryonated egg in sputum, and if it's around in the lungs, or if it's suggested in the liver, if it has settled in the liver, that can give unembryonated eggs in the stool as well. And then embryonated eggs in the water. Mira cercariae, you have a snail, and then obviously cercariae, and then metacercariae. Obviously, in all of this case, what does the chief complaint of the patient? The patient has asthmatic episodes, not asthmatic, but has a lot of cough. He doesn't have asthma because the lung parenchyma is involved. Note, he has cough, he has brownish sputum, even certain amount of hemoptysis, and then he has chronic bronchitis because of obvious inflammation with cough and pain. Now, the important thing that I need you to understand is that there is an eosinophilic. This is a very important question. It comes as an eosinophilic granulomatous inflammation of the lung fields, of lung parenchyma. Okay, and that too of the right lung. So if it comes as a right lung parenchyma, you want to think of this. And once the cyst ruptures, it can go into the liver. It can granulomatous inflammation. If the granulomatous inflammation has a cyst and the cyst ruptures, so the cyst can enter into the liver, into the CNS, etc., etc. How do you diagnose it? You want to do a lung biopsy, you want to do a sputum, you want to do a PCR, ELISA to check for antibodies, and again you want to treat it with the same drug, that's praziquantel. This drug is a wonder drug. I really like that. Now the other one that I told you I'll speak about is schistosome. Okay, schistosome. Schistosome has a lot of types. S. japonicum. Remember, japonicum has no, very important is that it has no spine at the egg. Remember, S. hematobium has a terminal spine. And last but not the least, remember S. mansoni. S. mansoni has a lateral spine. S. mansoni. Lateral spine. Okay. Why I'm saying this? Because all of them are non-opiculated eggs. Now, S. japonicum, S. hematobium, S. mansoni. S. hematobium is for the bladder. S. mansoni is for the GI. And more than GI, I say liver. Even S. japonicum is for the liver. What is the life cycle? Again, here it's not metacercariae, it's cercariae. Cercariae enters, it penetrates the skin. This is very important. Okay, it emerges from the snail and directly the cercariae penetrates. Okay, so it enters from the venous plexus into the portal. So can affect, obviously can go to the portal veins, and can enter the rectum or bladder. Correct. Rectal veins and bladder veins, obviously. And then obviously it will form eggs. Correct. Eggs. And again those eggs penetrate, or they hatch, and when they hatch they go into the snail, and from the snail again cercariae is formed. Now this is a very very basic kind of classification. So what you should know, and this is all you should know also about schistosoma. But when you're talking about schistosoma types, the japonicum and the hematobium, okay, the japonicum and mansoni, okay, is one group, and hematobium is another. Now hematobium is going to be in the visceral plexus, that is the plexus of the vesicle plexus. Vesicle plexus. I don't know why did I say visceral. And this is going to be in the mesenteric plexus. Mesenteric, superior, inferior, both. Now the point I'm trying to make is that because they are infecting the mesenteric plexus, These Japonicum and Mansoni are going to have a lot of symptoms that can be associated with inflammation of the intestine, and obviously hepatosplenic as well. So let's look at that. Okay, S. japonicum or Mansoni. So what happens? First of all, you have a skin reaction. So in 2 to 3 days, you will have a maculopapular rash, and there will be a rash in the swimmers because of skin penetration. After that, you'll have this acute phase of the Katayama syndrome, acute Katayama syndrome. Okay, in that you will have a lot of antigen that is being released from egg, and that is going to lead to a lot of IgA, IgG, IgG complexes formed, and you will have a serum sickness like syndrome, and patient will have fever, lymphadenopathy, and HS megali, urticaria, stuff like that. Okay, then look at the chronic one. Chronic is something that I want you to focus upon. They are trapped in the venous plexus. Okay, now when they're trapped in venous plexus, that means they're going to have a sustained immune response. Now when they're trapped in the venous plexus, first you'll have an intestinal form where there's going to be granulomatous inflammation, and then there's going to be fibrosis. There's going to be thickening of the intestine. Of the small intestine, and of the small intestine. Will I say small intestine? No, definitely, depending upon where. Okay, so I think it's colon rectum because of the vesicles, because them being trapped there, usually colon rectum. And then because there is thickening, okay, there is also going to be certain amount of diarrhea. All right, I see that. Now let's talk about the hepatosplenic diseases. Now it reaches the granuloma, and plus fibrosis can also occur in the liver. So now see, if someone is asking you a classical case of liver, you want to talk about fasciola hepatica and Mansoni, and you can also talk about hematobium and japonicum. Okay, if someone's talking to you about a classical case of lungs and they are saying that it's a flatworm, you don't want to waste time, you want to go for a paragonymous. So similarly, here you have to also think of the hepatosplenomegaly, and it can lead to portal hypertension. Now how can it lead to hypertension? Is because hypertension by obstruction of blood flow. All right, and therefore you will have hepatomegaly, splenomegaly, ascites, the classical cases of hypertension, hepatosplenomegaly. Okay, it can also go to the pulmonary, and it can have a pulmonary involvement. It can damage the lungs because it's all a venous plexus based, correct? Anything that enters the veins is a little risky in cases of parasites. And you can also have neuroschistosomiasis, and especially japonicum. Japonicum is really small, so it can all the way be carried up to the CNS. In the CNS, especially in the parietal lobe. Okay, we see that. Even as japonicum is carried up to the parietal lobe, and it can lead to acute encephalitis, as I told you. Acute encephalitis. It can lead to the kidney, it can go to the kidney, etc. Carcinoma of the colon rectum can occur. Carcinoma of the liver can occur. Carcinoma of colon rectum. Why? Because of sustained inflammatory reaction, and of the liver can occur. But now all of this is relatively rare. That's what I'm trying to say. But let's look at S. hematobium. Now S. hematobium is a little different. Why? Because it goes to the vesical plexus, that is of the bladder. And therefore, first of all, you will have the acute case where you will have a swimmer's itch and you're going to have dermatitis, and along with that you will have the Katayama syndrome, same kind of thing. Okay, you'll have the syndrome, you'll have pain, you'll have wheezing. But eventually when it reaches the chronic stage, you're going to have this. So the spine, the lateral hematobium has a terminal spine. So the terminal spine is going to cause damage. Antigen is going to cause antigen induced damage. Okay, the antigen induced damage. And also very important is that you will have a lot of dysuria. You will have hematuria, you will have hematuria, and you will also have granuloma. You'll have granuloma, and uh, plus fibrotic changes. Like most of these cases, we've seen all of them having granuloma and fibrotic changes because of the inflammatory reaction. Simple as that. And then you'll have fibrosis of the urinary bladder. Okay, in heavy infections, male genitalia can also be involved, and elephantiasis can be seen. Okay, so what you will have is, if extreme case, elephantiasis because of blockage of the blocked lymph. Now the bladder is showing certain amount of fibrosis. So what's going to happen is that there's going to be kinking of the ureter, okay, obstruction. So this urine that's going to come is going to be obstructed, and that's going to lead to hydroureter and hydronephros. All right, that's bad. That's really bad, right? How do you want to diagnose it? Simple. Same. Antibody. Check for ELISA. Do antigen. First you do antigen, then you check for an antibody. And finally, what you can do is you can do a treatment of choice. That's again praziquantel. Obviously, you can also do a hatching test, and you can check for a motile miracidae. Okay, and that is about it when it comes to the flukes. Okay, a very important thing is largest fluke infecting man is, as I told you, F. Wuski. The largest tissue fluke is F. giganticum. The cholangiocarcinoma is caused obviously by Clonorchis opistrochus. Squamous cell carcinoma of the bladder. Sorry if I messed it out, but because of this fibrosis, there can also be a lot of squamous cell carcinoma of the bladder. So that's by schistosomia hematobium. TB-like disorder can be by flu-like by the paragonimus, and Katayama femur is S. japonicum. Okay. So I think that is about it when we are talking about all the flukes. Thank you, and let's talk about the trematodes or the cestodes in the next tapeworm in the next lecture.